This week on the BackTable podcast.
Don't hesitate. I mean, just do this. It is, I think, one of the best things in my long career that I have done to improve the care of the patients that I'm taking care of. You know, approach it being, as Ted Lasso would say, you know, be curious, not judgmental. Like, approach this in an open fashion. How can we do this best? How can we take our egos out of the picture? And I think I would encourage other folks, if they are going to engage in this kind of process, to do just what you had recommended and setting up kind of a formalized document that kind of clearly goes through all of the steps and all of the scenarios and how is this going to work, just to make sure that the work that you put in up front to make sure that it is successful is able to be carried throughout the entire time of the collaboration. It pays off in the long run.
Welcome BackTable listeners. I'm Amanda Buchanan. I'm going to be the host for today's show. I'm an associate professor and division chief of pediatric urology at the University of Kentucky. And today we're diving into talking about collaboration in urologic oncology care, why it matters, how it improves patient outcomes, and the challenges we face. I am joined by Pat Hensley, an adult urologic oncologist, and Dave Rodeberg, a pediatric general surgeon. As quick intros, Pat is an assistant professor of urology and pathology here at UK. His clinical practice spans the breadth of adult urologic oncology as well as abdominal reconstruction, and his academic interests are primarily focused on bladder and kidney cancers, with emphasis on clinical trial enrollment. He bleeds UK blue, having gone to medical school here and doing his residency here. He was actually a resident when I first started. And Dave is the Dr. Andrew Pulido Professor of Surgery and Chief of the Division of Pediatric Surgery here at UK. He is also the medical director of the Kentucky Children's Hospital Operative Services. He's been involved in basic and clinical cancer research broadly, but predominantly in pediatric sarcoma. He's been involved with IRSG and COG since 1999 and was the surgical vice chair of the Sarcoma Committee until very recently. He has been the chair and vice chair of the American Pediatric Surgical Association Cancer Committee and is on the executive committee as the surgical leader for Instruct, which is a large international rhabdomyosarcoma group. He joined UK about 3 years ago. So welcome, Dave and Pat. Thanks so much for being here today.
Thanks for having us, Amanda.
Thanks, Amanda.
So all of us work together at the University of Kentucky, and we frequently collaborate on complex cases, especially renal masses and testicular cancer. Our focus today is going to be on how we work together, not the nitty-gritty details of treatments, outcomes, specifics of how you treat a 16-year-old versus an 18-year-old with various diseases, but really the importance of professional collaboration, quality of care, and we're going to get into a little bit of a touchy subject of breaking down traditional turf wars. So let's start super broad. Dave and then Pat, can you share some simple but powerful ways that you collaborate with other specialties daily that improve patient care?
Mm-hmm. Well, since I work in general pediatric surgery, right? So we do all the pediatric surgery here at UK, but that means I collaborate with the ED, with the Peds ICU, with the neonatal intensive care unit, with the medical subspecialties, with the pediatric hematology oncology group. So all of those folks are people that I collaborate with on a daily basis. In addition, in my leadership roles within the hospital, I also collaborate with leadership within the OR as well as the Children's Hospital itself. And I think, you know, what is important about the collaboration is really trying to be a good listener. That is not usually a strength for surgeons, and I freely admit that it is something I have to work at, to be a good listener and to keep an open mind and be willing to listen and accept other perspectives and points of view. And then as you're listening, to think about what is the middle ground, what is the common ground, what can we agree upon, and then how can we build from that? I do believe we all kind of come from a place of trying to do what's right, and it is rare to find people, especially in pediatrics, that are putting things other than the patient first.
Yeah, Pat, you kind of come from a little bit of a different world. So what experiences have you had, and even beyond oncology, what are some ways that interdepartmental collaboration has benefited your practice?
Yeah, I think, you know, kind of the most obvious example of collaboration as an adult oncologist is in our multidisciplinary clinics and tumor boards. We work on a daily basis with GU pathology, medical oncology, radiation medicine. Maybe more pertinent to this conversation is the role of a urologic oncologist as a collaborator in the operating room. We take care of a lot of advanced cancers in the pelvis and retroperitoneum. assist in a lot of advanced cancer states with our other surgical oncology colleagues, including GYN, colorectal cancers, and our sarcoma surgeons. And on the flip side, when I run into a tough case or have an advanced pelvic or retroperitoneal malignancy that's starting in the GU tract, super common to call in our colorectal surgery and surgical oncology colleagues on the adult side to kind of help out. I echo what Dave said. It's all about collaboration. We all have our different experiences and training backgrounds and approach cases a little bit differently. Differently is not a bad thing, and it can only add to the patient's care in my estimation. So
Great. So Dave, you've led major pediatric surgical oncology efforts, tons of huge groups, and it's really quite admirable. You've chaired lots of groups and that unite different surgeons from different disciplines. And this is kind of unique, right? A lot of people, they'll talk about kidney cancer, groups will talk about kidney cancer. When you talk about rhabdo, you're working with orthopods, ENT, neurosurgery, urology, general surgery. So what lessons have you learned from working across these disciplines?
Well, I have to say the working with the other surgical subspecialties is actually quite straightforward and easy. We're all surgeons. We all have a certain perspective. We all think that surgical care for patients is important and the surgical treatment for these tumors are important. And so I have actually found working with all of my surgical colleagues very easy and straightforward. What leads to more problems is the individual people, because regardless of the specialty, you'll find some folks that, get in there and do the work and are contributing and helpful. And you'll find other folks that much and a little bit struggle like, hey, where's that paper I sent you? And those kinds of things. But that's more the individual and not the specialty. I think my perspective is that in development of these treatment protocols, the tougher collaboration and the tougher interactions are with my oncology and radiation oncology colleagues. A lot of times I think some of our oncologists and radiation oncologists kind of look at surgery as, aggressive and mutilating and, slipshod because we have all different surgeons doing everything. Whereas our radiation oncologists are like, you get 45 gray over this many treatments to this field. And it becomes a very prescribed thing. So they kind of look at surgeons as a little bit willy-nilly. So even those relationships, as tough as they can sometimes be, trying to advocate for surgeons and surgical roles in the treatment, it is, again, about building relationships with the other subspecialties and, kind of building out those collaborations and those relationships, but also coming at them with data and saying, like, here's the data we have, here's what we do, here's what we're able to accomplish, and this is why the role we provide to the care of these patients is really important.
Yeah, I think that goes back to what you said before. Everyone's coming at a problem with good intentions. And everyone just has a different lens that they view things through. And no lens is wrong. And really, to be able to understand the different lenses only improves things overall. So, Pat, I have a little bit of a controversial question for you. And you can be very honest about this, regardless of the fact that I trained you. Do you think that pediatric urologists have a role in treating teenagers with testicular cancer beyond a radical orchiectomy? And where do you see their involvement stopping or continuing, especially for these advanced cases?
I think the short answer is absolutely. A surgeon's experience is highly dependent on their individual training. And I think more importantly, kind of the multidisciplinary team they surround themselves with. And whether that be a pediatric urologist or adult urologic oncologist like myself, we're all well aware that there's compelling data that for testis cancer and other GU malignancies like bladder, especially with surgeries like cystectomy, patients who undergo major cancer operations by high-volume surgeons at tertiary referral centers tend to do better from an oncologic standpoint and from a complication standpoint. Who those high-volume surgeons are at an individual center may vary. That can span the expertise of pediatrics and adult surgeons and pediatric urologists and pediatric general surgeons. And Amanda, I think your training and expertise is kind of case in point from a testis cancer perspective. You sought out lots of opportunities to get surgical exposure and expertise in RPL&D during your training and kind of early formative years of your faculty career here at UK. And you've established yourself as kind of a content expert within our institution and within our team, and certainly within our department. some pediatric urologists may have considerably less experience with advanced testis cancer and RPLND and may not contribute in a meaningful way to their referral center's care pathway for advanced testis cancer, and that's okay. The same paradigm exists for adult urologic oncology, and I think we always have to consider what's in the patient's best interest. Even though I'm a high-volume testis cancer surgeon here at UK, I always offer my patients a referral down the road to Indiana University, who, as we all know, are kind of considered the world's foremost leaders in testis cancer. So I think you never be too proud to involve your colleagues. Recommend, a second or third opinion to your patients if feasible. It's just got to be in a collaborative feel.
Yeah, I couldn't agree more, even though I do RPLNDs and which I don't think is necessarily super typical for a pediatric urologist, and that's okay. I also offer all of them, including the teenagers, the 15, 16, 17-year-olds. I tell them all about Indiana, and some go there, and, that's great for them. Otherwise, if they're going to stay here with me, I make sure that you are available and there to help me with that case, should we need. All right, so moving on to clinical trials and research collaborations. So the Children's Oncology Group, or COG, has studies that are open to adults, not just kids, including one comparing carbo versus cisplatin for testicular cancer. So Pat, this is really interesting because in the adult world, cisplatin is, considered it is the gold standard. We will not move from cisplatin. So do you think this type of study is valuable? And do you think it could ever gain traction with adult oncology groups?
I certainly appreciate the value in such a trial. The outcomes for a testis cancer patient, it's a very unique cancer compared to some of the adult malignancies that I treat. And that even in the metastatic and treatment refractory states, our oncologic outcomes and survival is generally pretty good. And I think that there's kind of due emphasis being placed on de-intensification of treatment while maintaining kind of excellent cancer outcomes. In this case, the trial's looking at adjusting, the efficacy while limiting some toxicity of systemic therapy agents in the lower risk setting specifically. And I kind of commend COG for tackling this and including adults, but I have some concerns about kind of the willingness of adult surgeons to enroll in such a trial. And this is not because adult surgeons don't believe in the importance or the equipoise here between the treatment regimens, but because adult oncologists are just not plugged into COG, like myself, as a prime example. So curious to see what your thoughts on this as well.
Well, that leads perfectly into the next question I was going to ask Dave, because he's super familiar with COG, having been both on the outside and the inside. So he's got, the behind the curtain view as well. So Dave, for those that are less familiar, like our adult oncology colleagues, tell us about COG. What's involved with enrolling patients onto studies? What barriers exist for people that aren't, officially affiliated with COG?
The Children's Oncology Group is the large national collaboration where we develop the treatment and therapeutic protocols for children with cancer. Now, a lot of these studies will also be open up to young adults as well as even older adults that have pediatric type of tumors. The problem is that in order to enroll patients on COG studies, you either have to be a COG center or you have to be affiliated with the COG center. The reason for that is that all of these studies, these clinical trials, require an IRB to be in place. There also needs to be the people that are able to abstract the data from the charts and enter it into the COG database. And so all of that infrastructure really takes time to get into place. And, it's not for people that are going to be doing 1 or 2 patients a year. Having said that, so like a lot of times, you'll find that surgeons will remove a tumor or biopsy a tumor or remove something, not really realizing that it's a cancer. And so that'll be some general surgeon someplace or a urologist or ENT person. But once you've identified that it is a cancer and that it is something that would be covered by COG, you need to enroll the patients in the study, usually by either being a COG center yourself or referring to another COG center.
So Pat, as an adult urologic oncologist, have you ever personally engaged with COG? And, what differences do you see compared to the adult collaborative groups like SWOG, for example, that everyone in urology is familiar with?
Yeah, I personally have no practical experience with COG. In the adult oncology world, we have a number of cooperative groups, while, COG is kind of the dominant leader in the peds and adolescent world. Adult world, we have ECOG, SWOG, Alliance, NRG, et cetera. And it seems like the individual cooperative groups kind of work in silos on trial design, which makes adult cooperative groups a little less nimble than COG, I think. But there's often considerable crosstalk and kind of cross-group support for trials and champions that from each individual cooperative group that support, a trial design from an individual group. It begs a question, specifically in the trial that you mentioned before for the testis cancer patients that are using kids and adults. Is there a role for COG to kind of get a adult cooperative group to kind of co-champion a study and get members in the steering committees from multiple different disciplines and cooperative group leadership from the peds and adult world to kind of collaborate on such a trial? I don't know if there's a precedent for that, Dave, if you've had any experience with that.
Yeah. So if I could address just a couple of things you said. So one, you will not find anybody within COG that thinks that it is nimble and quick.
That is true.
So in addition, there is only one children's cooperative group because the pediatric cancers are just so less frequent. We don't have that capability to branch out into multiple cooperative groups that will be addressing the same types of tumors. Because for, some cancers, solid cancers, you have 200 to 500 cases a year within the United States. That's unheard of for adult tumors. But yes, cooperating and developing collaborations with adult cooperative groups. So the non-rhabdo soft tissue sarcoma last trial involved both the pediatric COG as well as the adult cooperative groups in one large combined study. It was, because it was the first one, it was challenging, but it did start to develop the pattern and so should allow for future collaborations across kind of that age gap.
Yeah, and I think Aditya Bagrodia at UCSD has really gotten involved with the Germ Cell Tumor Committee with COG, and I know that I'm not entirely sure if it's the Carbo and Cisplatin trial, but there are trials that Alliance is kind of co-sponsoring, and even throughout the world, with the Japanese groups and Australian groups and whatnot, there is the beginnings of that. And I think, Dave, to your point, that's just because what we deal with is so rare. And for us to actually make any meaningful contributions, we just have to all work together. And so it has forced our hand. So Dave, any really practical advice for people who find COG difficult to navigate? So let's say someone like Pat, who didn't have a peds urologist who was super into cancer on his faculty, right? Because Pat would just ask me. But what would you say to them about, okay, you've got a 25-year-old with Wilms tumor. Okay, yeah, you should be enrolling this patient on COG trials or at least talking to people who are familiar with them. How do they do it?
The COG for all of the different diseases have the committee. It's posted, so who are the surgeons, who are the oncologists, who are the radiation people for each of the diseases, as well as for the individual trials. And so if you have a specific patient that you have questions about, you can always reach out to the study people to ask them questions about the study and enrollment and the treatment on that trial and to seek advice about how to manage the patient that you have. But even still, then that can be an advice or a guideline or a thought. But unless you're in a COG institution, you're not going to be able to enroll those patients on the protocols.
I think when some of the people that trained me have called me about an adult Wilms or some weird, pediatric cancer in an adult, and they say, well, how do I access this? My oncologists maybe don't know about the trials. What I have told them is to reach out to their corresponding sort of pediatric institution. And usually you can find someone there who might be able to help. And so really that may be one area that as adult oncologists, if you're seeing these patients, really reach out to some of your people, because they'll at least probably be able to guide you to where to go. All right, so switching gears totally, now we're going to talk about kidney tumors because this is such a hot topic amongst both pediatric urologists and pediatric surgeons, and certainly sparks some strong opinions. So I think in general across the country, unilateral nephrectomies are actually usually led by pediatric surgeons. Partials, there's a lot more involvement of urologists. But in the adult world, kidney cancer is basically only in the realm of a urologic oncologist. Now, IR is starting to get a little bit into that, but pretty much it's dominated by urology. So Dave, let's start with a controversial question for you. I'm going to put you on the spot a little bit. What role, if any, do you think pediatric urologists have in treating kids with kidney cancers?
Well, I think their role is confined to standing in the back of the room, kind of out of the way. It should be.
Yeah, that's exactly how it happens when we operate together, right?
Yeah, I'm sitting there trying to get to the table so that I could do something. No, I mean, I'm clearly joking. I think you're right that usually a unilateral renal resection in pediatric patients would be done by pediatric general surgeons. But I think given the amount of expertise and experience that pediatric urologists have doing retroperitoneal lymph node dissections and other work there in the removing those lymph node basins. And then, of course, doing the partial nephrectomies. I mean, that is not something that I think most pediatric general surgeons feel really comfortable with. So I think there are areas where the collaboration with pediatric urology just brings so much more to the table. It just makes it better for the patient. It makes it better for the surgeons. When we started, I really had no hesitations about doing this collaboration. But as we have done it, it has only shown me just how much better it can be.
Awesome. Awesome. So we're going to talk about kind of this exact challenge that we had at UK, which is not unlike probably every children's hospital in the country. There's kind of this turf war where you've got pediatric surgeons, and in some places, pediatric urologists are interested, and some they're not. But we've got kind of overlapping roles in kidney cancer care. And so, Dave, we worked together along with one of your junior partners, Eric Rallinger, about 18 months ago. And we sat down and we said, okay, how do we do this together? And we created this formal memorandum of understanding for all kids with masses suspicious for cancer in their kidneys. To summarize kind of for our listeners, all our patients are evaluated together as a surgical team. So a peds urology attending and a pediatric surgery attending go see the patient and family together after we have reviewed imaging together, talked to our pediatric oncologists. We do all of our cases together. Unilaterals, bilaterals, partials, everything we do together. And then our post-op management, we also do together. So Pat, as an outsider and someone, you do have a supporting role in these cases. When we have a thrombus and things like that, we recognize you have more experience than we do. And so I always am talking to you and asking you to be around and whatnot. What are your thoughts on this model? And do you think that an adult urologic oncologist should be regularly involved in these cases?
Yeah, first, I just want to commend you guys as kind of the leaders of this team and kind of collaborating on this understanding and what has generated, I think, what is the most optimal care for kids. Turf wars are kind of a construct of egos, and I think you got to keep the patient kind of, first and foremost at the center of these discussions. As we mentioned previously, each surgeon brings with them nuances and expertise and clinical volume, and I think when appropriately channeled, it can only add to the quality of the care for these children. As you know, and as you mentioned, my role in management of peds renal masses is kind of limited. Reviewed imaging together. I've been around for your cases. I've rarely scrubbed, but I'm always happy to do that. And however I can, assist in these cases and the care of these patients, it's just nice to be kind of a helping hand. Being on standby for the challenging cases, in particular, thrombus, solitary kidney, et cetera, I think makes a lot of sense to have an adult urologic oncologist who has some experience and folks who do this on a weekly and monthly basis. But I certainly don't think adult urologists need to be routinely involved in these cases. And I think it's really institution dependent. And it goes back to who is that team at that institution and what experience do those members of the team bring.
So Dave, you also have an interesting perspective because you are a senior mentor to your entire division, and you have some very junior partners. And so when we first started talking about this, how did you feel and what concerns did you have, especially for some of your junior partners, and how have these evolved over time with us doing this?
I mean, honestly, I didn't have reservations about doing this. So one, I knew I've been at multiple other institutions through the years, and I've seen multiple models where, there was like I'm going to try to steal this patient before they ever hear about it, or slip a $10 bill to the oncologist to send the patient to me as opposed to them, or you alternate back and forth one after the other. And those were always just so unsatisfying and just fraught. And so, it was just unappealing, and I didn't want to have that here. And then you broached the idea of doing these as a collaborative project where we would do these all together. And so I really didn't have any reservations. I knew your interest in oncology. I knew your skill set in oncology. And so I knew that this was going to be a good project. In addition, knowing that we already weren't doing like the partial nephrectomies and things, I only saw it as a way to increase the numbers that each surgeon did for these renal tumors and allow my junior folks to see both senior people doing it as well as urologists doing it. So I only viewed it as a win-win for my junior faculty and all my faculty, as well as the patients.
Yeah, I thought the same thing is, well, we were doing all the partials and the unilaterals were kind of going back and forth, and it was this very awkward situation. We are all doing more by doing them together. And certainly when we started this, full transparency, we're not a huge children's hospital. We were getting 3 or 4, WILMs a year. And since we started this model, we have done 1 a month basically for over a year. And so our volume has increased. All of us have gotten so many more reps. I think, from a pure rep standpoint, it has only increased.
I agree.
As far as kind of why this collaboration works. So from a peds urology perspective, I already told you I love this. From a very selfish standpoint, it ensures that urology is involved in every case, just like it does for peds surgery. I think it increases our residents' exposure. And, for me, it mirrors the training model I had where I was always doing these cases with the pediatric surgeons in Colorado, as well as Nick Cost on the urology side. We talked about this. A rising tide lifts all boats. We're all doing more reps. I think we're working together more effectively. And I think that translates across anorectal malformations and all of the other cases we do. And what I've also been surprised at is that from a technical perspective, we don't need each other to do these cases. But working together, when we can go together to interventional radiology, pathology, radiology, and say, hey, we need to improve care with this aspect of what you guys are responsible for, it has only helped and improved outcomes, from at least from my perspective. Dave, I don't know if you have any other thoughts.
I agree. I think it has definitely improved the care that our patients received. I know the oncologists love it a lot more. Mm-hmm. They don't have to worry about who am I supposed to consult this time, or what do I need to do, or am I going to make this person angry? They know, and they were very supportive of us setting up this memorandum of understanding and working it as a collaborative team. I will say that when you proposed writing this up as a memorandum of understanding, I thought, that's just like so unnecessary. Do we really need to do that? But by putting in that effort kind of up front to establish the ground rules and the guidelines and just to make things clear about how it should work, it allowed us to modify it to provide the best care, but also it really helped alleviate and prevent potential future problems that would occur because of miscommunication or, I didn't think this was going to be important or, and then you find out that it really is. And it also then lays the groundwork for when, hiccups do happen, it provides the groundwork for how you go back and correct those things so that those hiccups don't occur again.
So kind of as you talked about, no collaboration's perfect. Let's talk about some negatives or neutral aspects of our setup. Like what do you think has been neutral or negative about this, Dave, if anything?
See, that's why I sit there and I pause. I knew you were going to ask this question. And I sat there and I thought about it for a long time. And I'll be honest, I don't have any. I don't think there are any negative things that have occurred because of this. I think it has only been positives. We have now, now that we have established this protocol and this way of handling things, it's been much easier now to roll it out to the junior residents and to the junior faculty and to everybody have everything in place so that everybody can participate in these cases. And I really have no downsides at all, other than like your music choice.
Well, that's why we alternate so that we can hear yours sometimes. So, Pat, one of the things that some of our residents have said is like they want to be across the table from me doing the nephrectomy with me. Okay. And anyone who has done a huge nephrectomy of a 15-centimeter renal mass on a 2-year-old, you're doing this ex vivo. You need all the hands, and you've got, even if you're the third person at the table, you can see super well, and you're actually super engaged in the surgery. So Do you think that this collaboration is negatively impacting our residence opportunity at all, Pat? Like, what are your thoughts on that, especially since, you were a resident here?
As both a resident and a fellow, I've been on both sides of the table. I've been kind of the first assist or lead surgeon. I've also been the third or fourth guy down the table. And the short answer is no. I don't think negatively impacts the resident education. Our residents get plenty of volume with open and MIS approaches to radical nephrectomy, partial nephrectomy, kidney reconstruction, et cetera. And, most of them go into the community and make renal mass surgery a huge part of their practice. But few will go on to have subspecialty expertise to take care of pediatric renal masses. I would just encourage you both to involve your trainees in kind of the multidisciplinary care of these patients, who to operate on, when to use, risk stratified neoadjuvant and adjuvant approaches, how to collaborate from a multidisciplinary standpoint and appropriately stage and care for these patients. The technical operative stuff from a urology standpoint, the residents will get that on their oncology and endourology services. I have no concerns about that at all.
Yeah, I think, Dave, one of the things that our groups are really modeling very well for both the urology and the general surgery residents is this working together piece. Because yes, they see it, but I don't think they see it so much in the operating room. So I think that has been something that while the residents might be frustrated, they're not, doing whatever dissection of the pancreas, which I'm quite happy also not to be doing, that they are still gaining a lot from just seeing how this works. And most of the time they are tying the renal hilum. Like, we're letting them do a lot of those fun, high stakes parts of the operation.
Yeah, no, I agree. I think it has only been a good thing for our residents. And I think the nice thing is also that working more closely together on these renal tumors just leads to closer collaboration across the board for all the things because there's a fair amount of overlap between pediatric surgery and urology. We both do hernias and other things like that. So it has just led to better collaboration across the board.
So let's get into like the really exciting stuff that we enjoy about working together. So Pat, when we have operated together on older teenagers, and not just me, any of the pediatric urologists that you have operated with, what do you value most? What are you happy about having us across the table for you?
I just appreciate anytime I get the opportunity to kind of make a meaningful impact in a subset of patients I don't routinely get to work with. I think that's very exciting and kind of refreshing in my career. The way pediatric urologists approach complex urinary reconstruction and oncology fascinates me. We think differently. We're trained differently, and that's okay. As an adult oncologist, I kind of narrow-mindedly prioritize oncologic outcomes. And these are patients who are actively involved in making informed decisions for themselves. There's little emphasis on survivorship and long-term ramifications of, these disfiguring surgeries or morbid systemic therapy options that we put these patients through. Pediatric surgeons and pediatric urologists, I think, do a much better job of kind of holistically accounting for kind of the totality of treatment burden that we put on these patients. So I learn from you guys all the time.
So Dave, from your perspective, what are some little pearls that you have learned or enjoyed working closely with, your pediatric urology colleagues doing these cases?
I think for myself personally, I think the learning more about, because it was never a big part of my practice, but doing partial nephrectomies, the techniques for it, how to do it more effectively, cleaner, sealing up the open part of the kidney, getting that all taken care of. And then also just the lymph node dissection. You guys do so many more of those than we do, especially for like the, paratesticular rhabdos and things. That for me, those are the things that I have learned the most working with you and with the pediatric urology team.
Yeah. And I think, for me, one of the biggest benefits is that when I have a co-surgeon, whether Dave, it's you or it's you, Pat, I kind of joke that Pat, we joke about this all the time, that I have an emotional support surgeon. Okay. And the mental load of doing a massive operation when you've got someone as experienced or more experienced that's thinking through the same problems, thinking through the same decisions, worrying about complications. I mean, it has just been invaluable for me. Dave, I don't know if that has helped you at all.
I agree completely. It is the same. decreases your stress by at least half, because the other person knows exactly what needs to occur next. A lot of times as we're kind of proceeding through the dissection, it's like, here, you do this portion of it, you have a great angle at it, here you do this. And so you're proceeding in a way where you're kind of being ergonomic and optimal in how you're doing the dissection and how you're removing the tumor. It just flows so easy and so smoothly. It is lovely.
Yeah. And I know, Dave, we have had a couple that have had like massive mesenteric involvement and pancreas involvement. And I cannot tell you how relieved I was when I was like, oh, here, Dave, you're just going to do the pancreas dissection. And I didn't have to do it. And I wasn't going to get into any pancreatic issues. And of course, you didn't either. But, as a urologist, when you're not doing that all the time, I mean, it is so nice. That is not a high stress moment. And then post-op, of course, I worry about it, but I worry about it much less knowing that you did it as opposed to me. So final thoughts, Pat and then Dave, what would you tell your colleagues about our arrangement or what would you recommend to your colleagues if they wanted to pursue some type of collaboration like we have here?
I think you just have to be open-minded, just like you two were in leading this initiative. I appreciate you both and commend you for tackling this kind of difficult topic. I think you've done it in a very commendable way. As an adult surgeon, it's always a sincere pleasure kind of assisting in the care of kids and young adults, and however that looks, and whether that's actively involved in decision-making or operative planning or even scrubbing into operations, or like you said, just simply being that kind of emotional support surgeon during a tough case. I think we can all agree that more diverse minds kind of result in better patient care than working in a silo. And I can't emphasize enough, we've all worked in different institutions. That multidisciplinary team may look different for each institution because everybody comes with different interests and training and experience and caseloads and those kind of things. So just be open-minded and appreciate your colleagues.
Dave, what are your thoughts on that?
And I would echo all of that, but I would also say, don't hesitate. I mean, just do this. It is, I think, one of the best things in my long career that I have done to improve the care of the patients that I'm taking care of. Approach it being, as Ted Lasso would say, be curious, not judgmental. Approach this in an open fashion. How can we do this best? How can we take our egos out of the picture? And I think I would encourage other folks, if they are going to engage in this kind of process, to do just what you had recommended and setting up kind of a formalized document that kind of clearly goes through all of the steps and all of the scenarios and how is this going to work, just to make sure that the work that you put in up front to make sure that it is successful is able to be carried throughout the entire time of the collaboration. It pays off in the long run.
Yeah. And I think certainly if anyone is interested, if you want to contact me or Dave or Pat, we would be happy, at least I will speak for myself, I'd be happy to share our MOU. Dave, I can't imagine you would have any concerns about that. Yeah. Well, a huge thanks to both Dave and Pat for sharing your insights today. We hope to continue this conversation going in future episodes, maybe diving a little deeper into some nitty-gritty on how we can better serve young patients with urologic malignancies. And so thanks so much for listening, and we hope you enjoyed hearing about our collaboration at the University of Kentucky.
Thank you, guys. I really enjoyed this.
Thanks, Amanda and Dave.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.